So we were the winners of the before lunch staying on time race. So we're going to be the winners of the after lunch staying on time race. We did very well this morning. So congratulations to everybody who enjoyed their lunch because they already presented. And everybody else is all sugared up and ready to go. I did just want to take a moment to ask, we have two of our ministry colleagues with their mouths full of cupcakes at the back. Whoever's not chewing, you want to just stand up and just shout out your name and your role? That would be fantastic.
Hi, I'm Heather Nicol. I work with the bundle care team at the ministry and haven't been working as directly on the community work, but doing a lot of stuff related to the home care reporting aspect and also looking to be safe.
Excellent, thank you.
And I'm Stephanie Sue. I'm also on the bundle care team as team lead and really love taking this all in. So exciting.
Yeah. Lots of fun. Excellent. So thank you for being here. And I agree, we've had lots of great information and lots more to come this afternoon. So we're at implementation of appropriate, this is the longest title. Implementation, it hardly fits on the poster. We had this discussion, right? Implementation of appropriate rehabilitation care pathway following total hip arthroplasty. Jody, Anas, Marcella, and Charmaine, come on up. Woohoo! Let the sugar kick in. Woo!
We figured right after lunch you guys might start dozing, so that's okay. So just introducing myself, so I'm Jody Strick. I'm the Director of Outpatient Care and Business Development for Halton Healthcare.
Hi, my name is Marcella Honor. I'm the Manager of Orthopedics and Surgical Spine Units at Trillium Health Partners, Mississauga Hospital site.
And my name is Charmaine Lodge. I'm the Director of Professional Practice and Programming at the Mississauga Halton Lynn.
And I am Anas Ashraf. I am the Senior Lead Regional Programs with the Mississauga Halton Lynn.
So you can see we did quite an engagement approach in our project, and we wanted to use the Mississauga Halton Lynn and our hospitals within that Lynn in order to develop a care pathway post hip arthroplasty. We did sort of a lay of the land and looked at what was our focus and why did we want to focus on this. And basically, it was really because the bundle care is the responsibility of the bundle holder to drive that efficiency and also to be fiscally responsible within the bundle, as well continuing to make sure that we're abiding by best practice and putting the patient first. And so we felt that we've been able to do that by addressing this. So we already have in the Trillium site as well as Halton Healthcare, we already have established outpatient rehab departments. And so we felt for our journey, and what we really didn't know much about was really the home care sector. And Charmaine, coming from home and community care at the Lynn, was able to provide that to us in our group. And so basically, we came to understand that a majority of our total hip patients were going to home care and weren't being referred to outpatient rehab. And so we wanted to dive a little bit deeper into that to understand why that was happening, with the hopeful vision that our post-surgical total hip patients really should be receiving and accessing the right services at the right time in the right setting, and just sort of understanding what does that look like. So our theory was that when we looked at our initial data, it was really 90% of our total hips were going to home care, and less than 20% were being referred to outpatient rehab services. And so we really had to dive deep in to try to figure out why was that, because when we looked at, our both hospital sites were actually part of the provincial total knee project, and so our referrals to home care for knees are less than 5%. And so therefore they're either coming to outpatient care or they're going into the community and receiving care. So we felt that hips was something that we really wanted to understand further. So our aim statement was to increase the number of total hip patients being referred to outpatient physio to 80%. And whether that outpatient means our hospital sites or into the community, it didn't matter. We really just wanted them to get access to care and really understand why the driver to going to home care was so important, or what was driving that referral. So some of the diagnostic tools that we used the driver diagram, of course, the fishbone. We did some current state mapping analysis, of course, PDSA cycles, and we held a big Kaizen event. We did this with our surgeons, patient family advisors, as well as our members of our surgical floor team and RNs, and we really did a few events. So we looked at right from pre-op to prehab, to all the way through the journey, just to understand what that looks like, and then had calls with the LHIN and Home and Community Care, again, to ask the same questions, to sort of understand how are people accessing home care, and came to find out that a lot of primary drivers, it wasn't just inside the hospital, but it was patients self-referring, as well as referring through their family doctors as well. So, when we were looking at our change ideas, one of our initial change ideas was that we removed the tick box on the discharge order set form from our surgeons, and we were like, okay, done. We're good, it's off, they're no longer going to be referring to home care. And then the referrals still stayed very high, and we were like, we didn't understand what was happening, so we had to dive in deeper, and then came to understand that there was a lot of referrals coming from either self-referral or the family doctors, or even still the surgeons. They were handwriting it in. So, so again, doing a deeper dive to really understand what was driving those referrals. So some of the things that we looked at really to ensure best practice was we looked at updating our patient materials. We've heard that over and over again today, how important that education is. Standardizing messaging for patients across all points of care. And we also developed a 24/7 care line so that patients could call in, and that was put into the information packages. We used some technology at the Halton site, DashMD, which is an app that has the post-surgical approach on it and the information, so that there's different mediums that they can be looking at. At the Halton site, and one thing I would say, and Anas will talk to it a little bit later, is that we really learned from organization to organization. And it was actually surprising when we pulled our data. So Trillium at the M site, and then as well as Halton, our data was very similar. And so, if we had 78% of people still getting referred to home care, so did they. If we had, their prehab volumes were a bit higher, but we took that as an opportunity to learn from each other. What are you doing that we're not doing? And then the same thing for them in the outpatient sector. What are you doing that we're not doing? So we really took an opportunity to analyze, to remove the egos from the room, and really just take a look at what is best practice, and have a consistent approach across our LHIN. So no matter which organization they're going to, because we do refer to each other. You can have your surgery done at Trillium and come into Oakville for your post-op care. So really looking at that. So Oakville had to decouple their pre-op and their prehab classes. We offer now evenings and Saturdays for prehab appointments. We altered the model of care for that. We made it mandatory. So our surgeons in the room with us actually agreed that the education was extremely important, and it helped set the expectations of care. And they now say, if you don't come to prehab, you're not getting your surgery done. Where it used to be just pre-op. So they used to squeeze people in a week before and get their pre-op done even 2 days before. And then who cares about prehab? And so now I think the message is there, and they've actually come to the table to say that. I told you about taking off the checkbox. We developed a standardized criteria for home care, and then we looked at an innovation approach. So we're out right now to RFP as well. Trillium and ourselves, we're out together for a home care provider. And one of the things that we've asked for to be priced out separately of a rehab pathway is a home safety check. We heard that from the surgeons as well as the patients that this was very important, and they wanted to have that patient, that home safety check, maybe not after surgery, maybe before. And so we actually priced that separately outside of the home care bundle. So I think this has led to us to be able to bring in some standardization and some innovation as well into our approach. We developed a Meditech referral, so now when you're on the floors, immediately the referral immediately goes down, and then the patient leaves with their outpatient appointment in hand as part of their discharge order sets, and that's entered as a discharge order set and as they're leaving. And then we follow up in the 48-hour phone call. Did you get your appointment? Are you okay? Are you on track? Is there any questions with regards to that? You having problems with transportation? And then we'll fill out forms on the floor for public transport, whether it's caravan or other things, if that's an issue. So our process measures, so we went from percentage of referrals for outpatient rehab, our goal was 80%, and we're actually at 78% today. And we made the goal till the end of fiscal year, so we feel like we still have time to sort of make that happen. And you can see on our poster, we were very impressed that we got a trend line. So learned what that was. And percentage of patients attending prehab, so we went from 48% to 78%, or to 87%. This month, we hit 100% for the first time. A length of stay, we went from 3.8 days of length of stay to 2.4. So again, we have an orthopedics balance scorecard. There's a little bit of naming and shaming going on, I would have to say, where we bring up the surgeons' names and they compare to each other. And like somebody said, it's very competitive. They want to have the lowest score. They want to make sure that they're in line. And we do call out the people that there may have been, a one-off where there was a complication or something else, and so that doesn't affect their bottom line. Our balancing measures were the number of hips coming back into the ED and being readmitted within 30 days, so that's 0. And so it stayed at 0, so that's great. Percent of patients being referred to home care, 78%. So that remained high because of the innovation around the home safety check, but we realized that almost 100% of those are only getting one visit and one safety check. And our patient satisfaction, we use the WAD-LX score, and we went from an 86% to 94%. People have the comments that they feel that they're being taken care of. They feel that they have somebody to talk to, and they feel less scared about their journey. So what did we learn from all of this? Basically that changes in process do not necessarily change everything. You have to look at changes in behavior. So removing the ticks box doesn't necessarily make everything good. And then also making sure that we have everybody engaged right across from, every single step through the continuum of the care that the patient would experience. So impact and spread. So we did this at the Oakville site only, and so we have a Milton and Georgetown site, and then at Trillium being able to spread that.
Excellent.
Yeah,
Thank you. You do have to admire the perseverance of those surgeons to write the box back in. I thought that was fantastic. Carissa, what are you curious about?
Turn on my mic. There we go.
There you go.
Well done. That's so exciting. I have so many notes, but you've hit so many points. The role of prehab is part of the preoperative process, and it's not just the surgical visit 2 days before, but it's planning for that elective procedure and what needs to happen after surgery. So that's excellent. You mentioned the WAD-LX. So I was mentioning to a few people at lunch today just to highlight that tool is now being offered through NRC Health to OHA members. Yeah. So that I think that would take some of the data burden off sites. This might be sort of a question for future spread, and I love how you've engaged, the whole LHIN in this system level process. Because you're part of the GTA where many of these LHIN boundaries are very permeable, I'm wondering if you've had any thoughts for future, not to put pressure on now, but you can't always control the referrals that are being made to your home and community care from out of LHIN providers, and if you've potentially given that some future thought.
So that's a great question. So as part of Bundled Care Day through the Ministry of Health, we actually got where are the percentage of the people going from our specific hospital sites. And so we actually have working groups with our LHIN and other LHINs now where the majority of our patients are going. So for example, for Trillium, we have William Osler and Central West. And so we've formed a bit of a working committee so that we can actually develop a care path that not only translates to our patient pathway, and so the expectations would be set up and they would be similar and reflective, and so we would be able to pass that referral off to another LHIN. And I was just having a conversation with Joe Brandt about that as well today and how we can make that happen. So hoping to have a phone number or something that we can be setting up the same sort of transfer and then being able to pass people back and forth across LHIN boundaries. Mm-hmm.
Actually, I also would just from general learning from this whole project, and alongside the ideas team that we have here, the same members on the team are part of a collaborative that's happening in the Mississauga Halton LHIN, where we are meeting with both hospitals. We have only 2 hospitals, Halton Healthcare and THP in the Mississauga Halton LHIN. So we're meeting regularly and identifying ideas for standardization, for example, ideas to look into where we can be efficient and what are the things that we're expecting, especially from opportunities and also from high risks. And based on that, for one of the working groups that came from that collaborative is that we'll look into data and reporting, which we will be kind of thinking of how we can track those patients who are leaving the hospital and going with a referral for home care. One of the things that we found in the data analysis is that even though you are referred to home care, it's not necessarily that you're getting it in Mississauga Halton, right? So maybe you're going somewhere else. And this is work in progress. And again, for us, ideas work was just 4 hips. but we definitely are continuing this work for knees, and also like the same group will be continuing meeting and with many other stakeholders from both hospitals, okay, how we can do data and reporting, as I said, models of care, developing the model of care, and it is great that THP and Halton Healthcare now are developing like the RFP together. So this is a great opportunity for standardization, and also we're looking into other areas like financial reconciliation that will be happening also like in the future. So all of that is being raised at the collaborative, which maybe everyone can benefit from that too.
Excellent, thank you. Carolyn?
So one of the things I was really interested in was the home safety check, but in a few different levels. One is curious to know about that process, and are you working with one provider who's doing that work? But I think it's also a window into, and this has been our experience in ICC, is looking at the data in a different way. So not just an absolute, what is the referral to home care for that first visit, but really looking at the context of, you may still have, I think it was 75% or so that are getting home care visit in the home, but it really is just one visit with that. So it's looking at that data in a very different way and looking at it as a bundle. So I'm wondering if you could just maybe speak about that home safety check.
So, yeah, we were actually surprised to hear like how important that was from our surgeon's perspective, because if you're asking me to decrease my length of stay, I want to make sure that the patient is safe. And so we developed also a screening tool, so be good to compare screening tools in our prehab, and we identify people who need the screen. And because we decoupled pre-op and prehab, we're actually, in Trillium was already doing this, we're doing our prehab at least 2 months ahead of time now. So it gives people time to identify if there's issues, and then we can do a home safety check, or we can also try to get them in touch with resources like respite care or equipment or whatever it happens to be. We have time instead of your surgery's tomorrow, your prehab's today, and let's go, right? And so that was kind of the old model, and so now that's what it's given. And part of the RFP process is we ask them to model what would that home safety visit look like, and some of the innovation is we're actually probably going to be doing some of it before the surgery, make sure they're ready, right? And so therefore we're not going to have that, not going to hopefully have some of the issues that we're having today. So.
Thank you. So I'm sure you got lots of questions for this team, but you're going to have to find them after our closing today to keep us on time. So thank you, folks. Great job. Thank you. You've lost the flow. Guys, you've lost the flow. Look at you. You never follow the rules. So as these folks transition to their paparazzi episode, patient-driven goal-setting tool within total joint replacement journey. Oh, maybe you're the longest title. Aligning 3 organizations, Janet and Beth and Melanie. I was going to say Melissa. I don't know where that came from. Don't know what. Yeah, I think you. Most words per advisor. That's what I'm going.
There you go. Thanks, Alice. So as Alice said, my name's Beth Chevalier. I'm a physiotherapist from Queensway Carleton Hospital. We have Melanie Farmer from L'Hôpital Montfort and Janet Brooks from the Lynn Home and Community Care, Champlain. So as Alice also said, our project was called a patient-driven goal-setting tool within the total joint replacement journey, aligning 3 organizations. We wanted to focus on this project because we felt the total replacement journey had become maybe a bit cookie cutter, and at times perhaps we were focusing on the wrong criteria from discharge from physiotherapy. We felt goals were being put upon the patient rather than having a more focused discussion around what the patient really wanted out of their surgery. When we started, we had hoped to empower the patients to have more information around their decision-making and motivate them to work harder towards their personal goals. We hope to set expectations early and make patients the center of the decision-making process. Our theory was that if we could start the consultation right away from the initial visit with the surgeon, then we would all be on the same page. Keeping in mind it takes a lot of repetition to have a message heard, our theory was the earlier the better, then we could continue this conversation through to their rehabilitation. And so this led us to our aim statement, which is 70% of our patients who undergo a total joint replacement at one of our hospitals and who do their physiotherapy at Queensway or L'Hôpital Montfort or at Lynn Home and Community Care will complete a patient-centered goal-setting tool by August 31st, 2018.
In order to understand more about our project, We had to examine what would be the best to study and to find the best focus for our change idea. To do a root cause analysis, we developed brainstorming sessions with each of our organizations. We included physiotherapists, rehab assistants, and patients. We asked a few key questions to start and then drilled down using the 5 whys technique to find groups of reasons that delayed discharge from physiotherapy. We let everyone know that there were no right nor wrong answers. At these meetings, we created dotmocracies, which led to our fishbone diagrams. From these 3 key meetings, we amalgamated our baseline data. Based on our diagnostic journey, we discovered that there was a great variety and often quite individual and primarily functional limitations that delayed patients' discharge from physiotherapy, and our first PDSA was born. With the information we had gathered, reviewing the literature and best practices, we decided to develop an individualized goal-setting tool which would be patient-centered. We've been fine-tuning this tool and deciding where best to implement it in our system for the most impact. This has led to several more PDSA cycles. We have also inserted a prem at physio discharge and a survey for the physios and surgeons to complete to gather information on their experience with using our tool. Our tests of change resulted in adjusting where to introduce the goal-setting tools to our patients. We initially had asked patients to fill it in after surgery while they were still in hospital and to take it to their first outpatient physiotherapy appointment. Then we tried having them fill it in while they were awaiting their first outpatient physiotherapy appointment in the waiting room. And finally, we've decided to implement it while they're waiting to see their orthopedic surgeon at the TJAC Total Joint Assessment clinic. So that's where we're introducing it at this point.
So our data show that our patients do appreciate our tool. We achieved 100% top box for our patients saying how they appreciate the possibility of discussing personal goals with their surgeon and how it was a helpful process. Again, 100% of our patients said that being able to set their own goals helped to motivate them to work harder to be able to achieve them. And also, 93% of patients have said that it actually helped to improve the end results of physiotherapy, stating things that how it helped to create focus and to bring the outcomes more real. Our surgeons also agreed on the importance of discussing personal goals before surgery, so preoperatively, with 88% top box. So commenting on things like how it helped to manage expectations and how to advise patients accordingly. When we tested when we asked the therapists who participated in our first PDSA cycle, so this is when we introduced the tool post-operatively, they were more divided with only 50% top box. And we attributed this to the fact that using a new tool for the therapist, it actually raised the tension, bringing them outside of the ideal zone. Therefore, another reason to focus more on the preoperative phase for our tool. So in the last few months, we've been through lots of goals. We've collected over 200 goals. And yes, there was some repetition. So the most common one were being able to walk again, going back to different leisure activities, or just reducing pain. But we were able to classify our goals in 32 different categories. With goals ranging from basic things such as, going back to bingo or being able to sit for 2 hours straight, all the way to going back to running or be able to complete the Camino, the San Diego Trail. So, great range. And we thought that that variety in our results was actually proof that, it is important to address patient-centered goals, both preoperatively with the surgeon, but also as we get close to the discharge and physiotherapy, and not rely strictly on the more traditional goals that we tend to use, such as, for example, achieving a certain range of motion. So, as we're now at our graduation day, the next steps for us will be to continue trialing our tool with the surgeon with our third PDSA cycle, which is just, we just modified the wording of our forms slightly, and hopefully adopt the tool, and so that we can make it an official document and start using it in all our surgeon clinic. Looking back as when we started this journey, I think we can say that our first big challenge was actually to try and decide on a subject, which of course we managed, and our supervisors and our managers helped overcome the second challenge, which was to find time for all of us to work on this together. And now the biggest challenge we face now is to ensure that the tool not only follows the patient from one department to the other, but also from one organization to the other. And finally, if we have any advice for anyone starting a quality improvement project, it would be, don't panic. Okay? It's normal to feel overwhelmed at the beginning, but the advisors are right. It does get better with time and ends up making sense. Also, do not underestimate the power of good communication and always be receptive to feedback, whether good or bad.
And we just want to take a minute and this opportunity to thank those who supported us through this journey. So all of the IDEA's leaders, the teaching has been absolutely so worthwhile and so important and is going to impact all of our careers. So we thank you for that. Also to our leadership team, Jeannie Bonnell, Carrie Cook, Lee Levesque, Marcel Thibault, Brian Smith, and our project manager, Lynn Fuller. And most of all, and last but not least, Alice. We couldn't have done it without you moving us forward along the journey with your guidance and leadership and your influence and wisdom. It's much appreciated.
Thank you. Thank you. Thank you. I just need that one little piece where they said that the advisors are right. We would like that. Can we cut that out? And thank you. We'll trademark that. Thank you very much, and thank you for that. We had lots of fun. Comments, questions, Carolyn?
So I'm intrigued by the patient goal setting and how it could be used going forward. And maybe this is something that's already in place, but it sounds like you have a baseline, because it's out of your clinics, that you would have a baseline in terms of the frequency of visits and time to reach their previous goals, and whether you've noted or will be measuring going forward, whether it impacts on the duration or the number of visits required in the clinic. Because it sounds like a really interesting opportunity to really measure the impact of that goal setting.
Yeah, so we haven't yet, but we do have the data from before we introduced the goal, so we could always measure it.
I'm not sure if my question is similar or different, but yeah, we are. Osmosis happening here. Will there be, and maybe it's because I'm not sure after lunch if I'm picking up on, so is the tool being administered at 3 points in time, or you sort of tweaked as you went and determined first at the post-op, then looked at outpatient rehab, and then the pre-surgical visit?
That's correct. It was introduced initially while the client was still in hospital, and then that was working well, but we thought we could improve it, and so we thought we'll introduce it while they're waiting for their initial assessment in an outpatient setting. And then as a result of being together with the group and hearing some other projects that people were working on, Melanie came up with the great idea.
Yeah, actually it was a suggestion from one of people in the audience that suggested that we would test it before they see the surgeon, which kind of makes sense because we can then address any unrealistic goals from the start so the patients are not deceived. So that's what we're doing now, and that's what we're going to be doing as of now. But the tool, ideally, the tool should follow the patient so that outpatient therapists have access to it and can address these goals as well.
So that's great. I wanted to acknowledge your project and I guess the one before lunch at the Northwest Lynn, because it sounds like it's like, oh, gut wrenching when something doesn't go right and you sort of have to put the brakes on and then change gears. So good for you for doing that, because I can imagine you would almost feel like 2 steps back, 1 step forward. But I think as we learned in this program, that's a key part of it, and learning, what doesn't work and taking stock and then redirecting. So
Very nice. Thank you, folks. Follow the pathway over to your paparazzi moment. So I think if you had, on paper, if you spelt out 2, you might have won longest title, but it's because you used the number. Maybe that's why you're not longest title. Optimizing patient and staff experience while achieving a two-day hospital stay for hip and knee replacement. So it's the A team. Andrew, Andre, Amy, with the S&C, Sarah and Catherine.
Thanks, Alice. Good afternoon, everyone. Thank you for the great presentations today. So we are from Sunnybrook Health Sciences Center, specifically the Holland Center, which is our dedicated orthopedic site for hip and knee total joint replacements. Basically, what we were looking at in our project is sort of twofold, looking at improving the patient and staff experience while also maintaining our 2-day length of stay, which just as a note, we've started back in November of last year, going from a 3-day length of stay to a 2-day length of stay. And so we're just working on improving the process and improving the experience for patients and their families and staff as well, and also maintaining that. So the decision to focus on this project mainly came from the fact that we were doing fairly well with our 2-day length of stay discharges in terms of the numbers, but we also recognized that there were areas that we wanted to improve, such as patient family education, optimizing discharge processes, and communication regarding discharge with our patients. So basically, in terms of the funding as well, we knew that the model was changing, and we thought it was really fundamental that we continued to work on these processes and improve our discharge. So the things that we wanted to look at were the patients and families' experience with the shorter hospital length of stay. And we had heard anecdotally from a number of patients and their family members that they felt rushed in the discharges, particularly on the second day of discharge, post-op day 2. And they felt that they were not clear on the discharge instructions, weren't totally clear when they went home because of the rush that was happening on day 2. Things like how to manage their pain, when to resume their home meds, and how to progress their exercises and activities were things that were specifically they wanted to know more about after they went home. So in our roles as frontline staff, we heard from our peers that the volume of discharges and admissions as well was at times overwhelming for the staff on the units. Staff were not always communicating well with each other in terms of discharge teaching, and this resulted in a lot of last-minute scrambling. And we hope that our change ideas would alleviate some of these challenges. So the theory was that if we can improve our discharge process and teaching, our patients would feel more supported and ready for discharge on day 2, thus ensuring that discharge targets were met as well as improving their experience. We also theorized that streamlined processes for staff would alleviate staff stress, which would then also translate to less stress for the patients while they're being discharged. So our aim statement, so by today, September 28th, 80% of patients who undergo primary hip and knee replacement at Sunnybrook's Holland Center will be discharged home by post-op day 2. And so going through this journey, we initially created a process map of the continuum of care for hip and knee replacement surgery. We completed a driver diagram and identifying primary and secondary factors contributing to delayed discharge. We did an audit of 34 charts and confirmed that pain issues, slow rehab progress, or change in discharge plan, as well as nausea and dizziness were the primary factors that would delay a post-op day 2 discharge. And from the data that we obtained in these chart audits, we then created a Pareto chart and to illustrate the most significant reasons for delay of discharge. And to further explore the patient experience, we also created an experience-based questionnaire to give the patients, after they were coming back for their their clinic visit. This was a helpful tool, confirmed some of the challenges that we had known were happening, and identified that we were able to reinforce that we were on the right track in terms of our project. And I'll turn it over to Sarah.
So knowing we had a really short timeline to do this, we decided to focus on small changes to improve and streamline the discharge process. So based on our diagnostics and our understanding of the baseline data, we decided to try the following 4 change ideas. The first was to improve the use of whiteboards. So we really wanted to make sure that staff were consistently using the whiteboards to communicate estimated date of discharge to patients and families. The second idea was to improve communication regarding medication changes for home. So we had done a quick audit finding that approximately 30% of our patients had medication changes, usually relating to pain, on post-op day 1. And then often there would be a delay in their discharge on post-op day 2 because there would be an issue with the orthopedic surgeons or their fellows coming up to the unit to actually change the prescriptions for going home. So we decided that we really needed to improve communication there. The third idea was to implement a process to measure the patient and family experience of care regarding the 2-day length of stay. And that's when we created the questionnaire using an experience-based design or using the principles to really get an understanding of the emotional experience of patient and families. And we provided that in the outpatient department. And then based on what we were learning through the process, we realized it was really necessary to change our education materials. So we decided to edit or revise the discharge section of Sunnybrook's hip and knee patient guidebook. Really with the idea of enhancing staff teaching, allowing for all important dates to be focused in one area, and to incorporate the newly revised pain management information. So as we implemented these changes, we learned a number of things. The first was really the variability between the 2 units. So we have 2 surgical units, and although we used the same technique for staff education to really try to send out this information on using the whiteboards, but also getting their feedback and seeing why it wasn't being done consistently. What we did realize is that different staff or different units had very different cultures and really would require different approaches to making this change. But we did take the time to really focus on the message and being really clear with the whiteboard use. So it wasn't good enough to write home POD2 because that did not mean anything to patients and families, although it might have meant something to staff. We really emphasized writing something like home Thursday. So that got across, but still there was some inconsistencies. The other thing we did is we've developed a clipboard, so a communication board on the unit, so that nurses can communicate to the orthopedic fellows on post-op day 1 when there is that pain medication change. And then when the fellows round, early morning of post-op day 2, they'll use that clipboard, realize who needs changes to their prescriptions, and then they can write them out well before discharge time of around 11 a.m. Unfortunately, we haven't been able to put that into practice yet because we've had a full turnover of our orthopedic fellows. So we've provided the education to our new fellows, and we hope to really implement that in the future. Our survey, we had a good response rate from our questionnaire for patients and families, and we've piloted it with the results really informing other change ideas. And the guidebook, we've now revised the discharge section, and we're just waiting for feedback from our patient partners before we actually put that into production. So our data showed that for the months of July and August, we did achieve our aim of 80% of our total knee and total hip patients going home in 2 days. So we're happy with that. Next steps, so we're going to continue our work to try to increase that whiteboard use. We're going to work on those communication boards with the orthopedic fellows. And we're going to keep using that patient experience questionnaire to really get a good idea of how these change ideas are impacting our patients and their families. We also plan to explore the staff experience with this change in this 2-day length of stay, and we're going to focus on unit focus groups because we do recognize that they are 2 different cultures. And then we have an interdisciplinary committee that's going to continue to build on the work from this ideas project, and we're also going to be piloting a select group of patients for post-op day 1 and day 0 discharge. So to sum up, our biggest challenges have probably been organizational factors, the team dynamics and how they can affect change or the success of change. And collecting audit data, as another team mentioned, has been a big challenge, especially when it's not covered in our regular workflow. So, as we complete our ideas journey, we recognize that quality improvement is a continuous process, and we look forward to trying new or different small change ideas to improve our process and patient and staff experience, or to improve it. Thank you.
Excellent. Excellent. Thank you. The good news is they achieved their goal. The not so good news is then now the bar got moved up a little bit. But that's okay, right? That's continuous. That's the journey. Carissa, you get first one this time.
Okay. Maybe because you went last, this might be a hard question, but I'll throw it to you. So great work, and I do see that you've identified the opportunity for spread within the organization. I'm just wondering if there's been consideration, or you might think about how could you possibly spread this to other organizations within the Toronto Central Inn?
So some of the things we do at the Holland Center, like because we're so specialized, we do publish all our guides, or like published on our website. We're happy for anybody to use them as long as they reference that they came from us. So a lot of our discharge teaching and some of the summary pages where we're providing your follow-up appointments, your medication information, that's all going to be available once we officially go into production with producing that. I think we'll continue to try and disseminate, like in places like this, these sort of forums are the opportunities where we get to discuss. So we don't have a formal plan to disseminate any of the things we're doing, but I think as we move towards, I think where most of us are already working on this too, to say the home in one, that's an opportunity where I think in the next 6 months to a year we'll have lots of opportunities to spread that information.
And I know Toronto Central Inn and many other LINs have orthopedic planning tables as well, so that might be another opportunity to spread from a LIN perspective.
For sure.
Yeah. Great work.
Carolyn.
So I'm really interested in what the role of with planning and the whiteboards was with families, especially if you're looking at being more aggressive on that target of 1 day length of stay, and we know that anxiety sometimes from family members who are having to support them at home. So just curious what your thoughts are, what you've done to date, and maybe how you might engage them if it's even a more rapid cycle going forward.
So probably the first thing we did when we started this was we made sure that there was consistent messaging across our organization. We have a pretty extensive pre-op clinic because we don't really have some of the supports of a larger institution. So we really streamline and have a really intensive, but we identified that some of those people were giving the wrong messaging. So we really focused on ensuring that the whole team across the continuum was giving this 2 day length of stay. And the surgeons was probably our biggest challenge in making sure that they were all giving that message because they like to be everyone's best friend. I think that's where we really focused on that piece, and we were really lucky that we had great buy-in from all of our team members, and the messaging was very consistent. So when we had the challenges with families, we'd bring in, I'm one of the managers here, I'd bring in the social workers, we would get everyone involved as we needed. But I think because the messaging started so early at the pre-op, we're doing really well with that.
Yes, Jody, do we have time for Agnes to get her steps in again? 9,999, 10,000.
I was just wondering because we implemented a phone line, so we call them back at 48 hours. And one of the things we're finding as we're reducing the length of stay is that the pain is a constant concern. And I was just wondering how your maybe pain service or somebody is addressing that, because we find they go home and the other issues with MedRec is one, but also maybe the pain meds they received weren't adequate or they had a reaction. And how do you address that with the decreased length of stay?
Yeah, that is what we struggle with too. And especially going from 3 days to 2 days, it seems to be much more of an issue that patients are just learning how to cope with their pain once they get home. So we have a pain team that's meeting that's going to strategize about possibly starting the routine of the home medication right from the start. So removing some of the things that we have in place, like nerve blocks and things that give the patient sort of a false sense of what the pain is. So that we haven't rolled that all out yet, but that is our strategy. But we also do the 48-hour call for patients, so we have that same experience. And I was just going to say about sharing with the hospitals in the Toronto Central LHIN, because we have a very established outpatient department that follows the RCA guidelines for rehab. We do host lots of sites to come and see how the knee class runs and things like that. So that's sort of how we're informally sharing, is we welcome visitors to come and ask questions and see the outpatient classes.
Excellent. Do we have another question over here? Yeah. 10,001, 10,000.
Congratulations. I have more of a practical question, and mine would be, so you're reducing the length of stay, patients go home day 2, but what are you doing with your beds? Normally your patients would stay 3 days or plus or whatever. But what's happening to your beds on day 3? Are they staying vacant? Are you doing more cases or?
So we recently did a nice little renovation of our operating room. We now have 5 operating rooms. We are slowly ramping up and doing more and more surgeries. So we're filling them with surgical patients. We also, our facility also does some other work of offloading some of the ALC pressures of our main site as well. But we, on a Thursday and Friday, have every single one of our surgical beds filled. So it's just we've ramped up our surgeries. Like we're 2,300 joints a year. So, and that will increase.
Thank you, folks. Move over for your photo op. Are they ready next door? So I think I'm going to put Carolyn and Carissa on the spot for a moment because I don't hear clapping next door. So I think once again we have stayed on time and they have not, just want to say. But just because the wall has to come up and all of those things, I'm going to put Carissa and Carolyn on the spot for a moment. And, you know, one of the things that teams shared today was sort of their advice, so their lessons learned. So you guys graduated, I'm just going to say a while ago, because I don't want anyone to know my university graduation date either. So a while ago, one word of advice to folks as this is their graduation day. What's your one piece of advice to these folks?
I think I would keep, I think you've got so many great learnings here, and so keep those at the forefront. We talked about standard messaging, engagement. We talked about the importance of data. I think I would underline that one because, yeah. Having continued with my quality work since I graduated from, I think, Cohort 2, that data is so important so that you can really help to evaluate the extent to which your efforts are making an impact and that you're having a difference in change, and then use that as a communication tool. So communication, we've heard, but data as well.
Did you hear that? Cohort 2. Yeah. Imagine, eh? You live after ideas, you do. Carolyn, how about from you?
So it may be my advice absolutely on those very important pieces around quality improvement, but I think what struck me today is the momentum of the teams. And I think when you're doing this work, I'm sure you'd all agree that when you're trying to drive the bus by yourself, it feels pretty lonely. But I think now you've built up these teams, and not just teams within one organization, but really partnerships. I think that's really the key to be able to drive a lot of these improvement processes.
Yeah, don't lose that all teach, all learn that we've developed really strongly here, yes. And I'm sure Joe will mention this at the end too, but our support as your advisors, we're still there. All that rich information on campus is still there. Like don't lose the momentum because you've done amazing things in a very short period of time with very little notice for some of you in the fact that you were actually going to take this approach. So congratulations to all of you. Yes, let's give a round of applause. Yes. And so give us a moment as this wall goes up because we are closing is together. And so Dr. Joshua Tepper is going to address us. And then we're going to hear and have a conversation with Lily from the Ministry of Health again. So Claire's just going to go and check on the other side and then the wall will come up. There might be a cupcake or two out there, which you guys might get access to. Few moments. Oh.